RAMP 301 showed a significant benefit in KRAS mutated patients. And so although this is a rare tumor, this represents a big advance for those patients. The presentation from ASCO 2025 was really important because it showed a significant overall survival benefit for treating patients with relacorilant in combination with a chemotherapy called Abraxane. Trust has showed that really the most important thing actually is that whenever you do the surgery, you do the right surgery. And you want a gynecologic oncologist, someone like me, involved in your surgery to remove as much of the cancer as possible. So really, low-grade serous ovarian cancer has been a tough cancer to treat for many years because we know it's resistant to most chemotherapies. The new combination of abibitnib and deactnib represents really a first-in-class novel combination to treat patients with low-grade serous ovarian cancer. There are two new mechanisms with two new pills that we really think are going to be better than chemotherapy. The most recent trial, RAMP 301, showed a significant benefit in KRAS mutated patients. And so although this is a rare tumor, this represents a big advance for those patients who have low-grade serous ovarian cancer that have a KRAS mutation in the tumor.
Why does adding relacorilant to chemo boost survival in hard-to-treat ovarian cancer?
Relacorilant represents a new class of drugs that we are using to treat ovarian cancer. The presentation from ASCO 2025 was really important because it showed a significant overall survival benefit for treating patients with relacorilant in combination with a chemotherapy called Abraxane. Relacorilant's a new class that it's a selective receptor antagonist for glucocorticoid receptors. And this is a mechanism we've not used before in ovarian cancer. And we're really excited because for patients who are no longer responding to platinum ovarian cancer drugs, platinum chemotherapy, this really represents a new pathway that we can now treat patients. And in a population where we can't offer them a platinum agent, it's really important to have more options. And the fact that there's an overall survival benefit is really a huge win for this group of women impacted by ovarian cancer.
When is it better to do surgery first versus chemo first for ovarian cancer?
Ovarian cancer is unfortunately usually found in late stage, meaning stage 3 or 4. For patients with stage 3 or 4 ovarian cancer, really the best option is a combination of surgery and chemotherapy. To date, for those patients who have a new diagnosis, it was a little unclear whether we start with chemotherapy or we start with surgery. A new trial that was just presented with data called Trust has showed that really the most important thing actually is that whenever you do the surgery, you do the right surgery. And you want a gynecologic oncologist, someone like me, involved in your surgery to remove as much of the cancer as possible. And so it found that whether you had chemotherapy first or you had surgery first, the better the surgery, the better the outcome. And so my advice for patients is that you should really get to a gynecologic oncologist to do your surgery. And if you're a medical oncologist, we want to partner with you to provide the best possible outcome for our patients.
Who benefits most from PARP inhibitors in ovarian cancer now?
PARP inhibitors have been an extremely important advance in the management of patients with ovarian cancer over the last 10 to 15 years. We've had this story generated over the data from the last few years where it now seems the best time to give PARP inhibitors is in the initial management of ovarian cancer, meaning the time of diagnosis. Someone has chemotherapy and surgery, and we need to identify those patients who have an HRD positive signature to their tumor or who are BRCA1 or 2 positive, because we know that's the time to give a PARP inhibitor. At that initial treatment, when you finished your chemotherapy, you should be on a PARP inhibitor as a maintenance strategy for 2 to 3 years. We know that patients who receive PARP inhibitors, who have these molecular signatures, will have the most benefit. And we may be curing some patients who might not otherwise have been cured by getting them on these oral drugs. And so really, if you're a patient, talk to your doctor about PARP inhibitors. If you're a medical oncologist or gynecologic oncologist, make sure you're testing your patients both molecularly in the tumor and also their germline DNA to find those patients who are going to benefit from a PARP inhibitor in the initial management of ovarian cancer.